Hello, everyone. So here we are, on another topic of the palliative care series. So today we are going to look at home-based care from the perspective of a general practitioner, but we may also consider other forms of home visits besides palliative care home visits. So this is a part of community-based care as well. So as a clinician who is living in the community as their patients, a general practitioner is very commonly required to make house calls. So earlier these were called as house calls. Moving on to the objectives, we will first have a look at the concept of home visits, acknowledge the contextual differences of home visits in different settings, and identify the indications for home visits. Why would a physician visit the patients in their households? To be able to arrange a home visit in a professional manner, to be able to discuss the advantages and disadvantages of home-based care to the patient as well as the health professional, to be able to justify when home visits are not necessary, and to be able to assess the patient at home and to be able to envision the future of home-based care. How would it be like in 10 years from now in Sri Lanka? So some of the ideas we might be able to get from what we see from overseas in the developed parts of the world, but then we should have our own vision as well. Historically, where do you think like home visits originated? Well, earlier in the ancient, so what is a home visit to start with? It is simply the doctor or the clinician visiting the patient at home. So this concept actually originated in the ancient Greece, where actually the modern medicine came into being, and physicians, most of all, have visited their patients who were really ill in their homes to give better care. So the ancient scripts, ancient fresco, and all that provide evidence to the fact that this has been a practice. So contextual variations. Okay, is it mandatory for the doctors to perform home visits at all? Do you think it is mandatory? Is it mandatory for a general practitioner to do home visits? Well, we will come to that. And what sort of doctors perform home visits? Is it generalists or specialists? Who decides whether a home visit is necessary or not? Patient, the family, or the doctor? How urgent is the home visit? Do you need to visit the patient within a few hours? Can you postpone it for a day? Or can you visit the patient within the course of the next week? So how urgent it is? Who visits the household? Is it the doctor visiting all by him or herself? Or is there a nurse accompanying? Or it is a whole interdisciplinary team visiting the patient? So the current trends. So home visits was really a big thing about 30 years back. For so many reasons, physicians happened to visit their patients. But what happened? Well, this trend is still there, especially in Europe, USA, Canada. They still practice it there. But what is the trend altogether overall? What is the global trend of home visits? It is declining. So the mainly attributed reasons are the time pressures that the physicians have to face and the inconveniences. We will see what these inconveniences are to a physician in doing a home visit. So, however, especially for family physicians, palliative physicians, geriatricians, the manner in which they have to do a home visit in a professional manner must be taught. That must be a part of their training. So now we know like what kind of doctors really need to know, really need to do home visits. So talking about the generalists, so there are general practitioners who historically were involved with this sort of care. And in addition, generalist palliative physicians, general practitioners who have been trained in palliative care, they visit the patients at home. And there is an effective palliative care model in Kerala where these doctors tend to visit their patients in households. And it is a very efficient community-based palliative care model that has attracted worldwide praise. And then specialists, do they home visits? Do they engage themselves with home visits? Yes, they do. Not very commonly, but this is actually a study that I'm quoting here. So these have been some of the beneficial aspects that these researchers have found out in making a home visit. Specialist home-based palliative care improved symptom control, health-related communication, and psychological support. It promoted increased number of home-based deaths. So, is a home-based death a good thing? Yes, it is, because the patients like to die at home rather than dying at hospitals. Appropriate and early hospice referrals and averted needless hospitalization. So you have to avoid hospitalizations as much as possible, especially when it comes to palliative care patients. So that has been achieved through these specialists visiting patients' homes. And it improved bereavement outcomes and caregiver satisfaction. So, and along with the physicians, the nurses and allied health professionals might also perform home visits. And in some settings, it is not just the doctor or the nurse, but there are entire teams visiting the patients in their households. So there are office-based nurse practitioners, dedicated social workers, administrative assistants. So this is another study that had shown that the patient satisfaction and everything has improved with this sort of interdisciplinary team visits. So does it happen in Sri Lanka? Yes, it does. So I personally know similar home-based care programs. Actually, the hospital-based staff make these home visits. There are reports from Mathara and Ratnapura, but there might be even more home-based care services. So the indications for home visits. Always it is best to have strict guidelines. So you follow the guideline always. So there are no conflicts of interest. So you are not making a decision to pay a home visit just because the patient can afford it, but because it is possible as per your guideline. That must be your principle. So to maintain your principle, to have your have a firm word on the ability to do a home visit, you have to have your strict guidelines. So, so how to set up a robust home visit policy? There is a guide by Dr. Susie Bailey. So one thing is that for the elderly and disabled patients, bedridden patients, you can do routine visits, monthly or even weekly if the patient is not so good, needs frequent care, then you decide on weekly visits. Otherwise, monthly is good enough. So you decide based on your clinical experience. So even you can visit them for their acute illnesses such as falls and respiratory illnesses. And then for palliative care patients and those who are terminally ill, you may want to visit them to give pain relief at home, IV fluids, subcutaneous fluids, wound dressings, catheter change, NG tube insertions. So the physician can also provide a good amount of psychological support, social support and care when you visit these palliative patients. Right, this is just a clinical scenario. You can read through and decide what are the options you have in this scenario to help the patient. This is not about the management of the patient. This is not about the clinical management. What strategic aspects do you have to attend to this patient and help this patient? So the third instance is emergencies. So some persons, elderly can face falls at home, and some people can have chest pain, severe backache. So you might do an initial assessment whether to manage the patient at home, depending on the resources available at home or with you, and the degree of family support available, or whether the patient needs to be admitted to a hospital. So, and how to transport. So you all have to decide all of these. And following discharge from a hospital, following a major surgery, you might want to visit the patient for, to alleviate certain concerns, do clarifications, do wound dressings, stoma care, to manage the tubes that have been put there surgically. You might want to visit the patient. Maternal perinatal care. So that was something that was really prevalent in the ancient times, where the doctor visited the patients, especially when there's a problem with the mother or the baby. So in the postpartum period, the mothers may have problems with their episiotomy, prolapsed hemorrhoids, tears, which you might have to suture and all that. And there can be many concerns around the care of the newcomer to the family, the baby, whether the baby was fully examined, and to correct the breastfeeding techniques, and how to protect the baby from infections and so on. Then there are infectious patients, for instance, those with chickenpox, who have the possibility of transmitting the illness, the infection to the other patients in your clinic. So better to see them at households, in their household, if you have got chickenpox yourself or if you are vaccinated. So then there are mentally ill patients, uncooperative patients, aggressive patients, and those with mentally retarded patients, those with cerebral palsy and who are poorly mobilized. They are another indication why you should do home visits. So bereavement care, when a patient dies in the house, and certification of death. So these are responsibilities of a GP. And then embarrassing situations such as rape and abuse, where the patients and even the family might not want to get exposed to the society or the village, so they might want to see you in private. To hold family meetings, conferences. This is happening more frequently in terms of palliative care, where the resources within the family needs to be examined by the doctor before resorting for to be able to help them better. Then out of hours care, emergency care. And In different contexts, we might also want to, the GPs are known to perform home visits. In the Netherlands and Belgium, where physician-assisted suicide is a big thing, the doctors, visit the patients. And then there are VIP patients. Well, that is not something that I recommend, but maybe for their security reasons, they tend to get home-based care. And then suspicion of child abuse is another reason why a home visit could be made by a GP. But in our Sri Lankan setting, if you suspect child abuse, the commonest thing to do would be to admit the patient, admit the child to a pediatric ward of a hospital so that a formal investigation is being carried out. So the procedure, what is the formal, the nice, professional manner of arranging a home visit? So for routine visits, the doctor inquires the general medical information of the patient, and also if the doctor has a medical record with them, they will go through the record and mutually decide whether a home visit is needed, agree on a time, and schedule the visit accordingly. For emergency visits, make the decision whether you are doing home visits for emergency instances. So in your policy, in your guideline, you may clearly decide that you are not performing home visits for emergencies, but only do a home visit on a routine basis for palliative patients and so on. For whenever an emergency occurs, you advise the patient to, visit the nearest hospital. Otherwise, if you are having busy clinic hours in the clinic, it will be really hard for you to make emergency, unprecedented visits. So how do you do the home visit? Then as you approach the house, you do the initial greetings, do the social interchange, have a bit of a chat, and then you try to cover the aspects why you are there for. So checking the vital signs, which you cannot do over the telephone. So you have visited for some reasons. So to check the vital signs, proper physical examination, obtaining blood samples, administration of drugs if required, issuing prescriptions, carrying out procedures such as urinary catheterization if it is needed, do health education, and do referrals if it is required. And in the same time, the physician is able to do a family assessment of the hazards within the household and the resources within the household. So those are some additional advantages there. So the pay, how much do you get paid for doing a home visit? Well, you can actually charge the patient, but not always. So if you have a policy to decide that you're going to have a very strict guideline on doing home visits, you may even decide to do the home visit free of charge when it is absolutely necessary. So you can accept the payment on site or later on. And would it depend on the patient's economy? Yes, depending on the patient's, if the patient is unable to afford, you may decide to waive off your charges. But what if your policy says you are not doing emergency home visits, but then you get a call and someone offers you a higher rate, an extravagant amount for doing a home visit? Would you still do a home visit? No, that is not a very ethical thing to do. So your decision to make a house call should not depend on the remuneration, how much you are being paid. Advantages to the doctor. Does it have any advantages? So what I'm going to list are mainly advantages to the patient But because the physician is able to do a proper assessment of the patient and the household, it is also advantageous to the doctor in arriving at a diagnosis and assessment. So the opportunity to see the patients in his own environment, how clean the environment is, the socio-economic condition, the layout at home, are there hazards, the bathrooms, are they slippery, are there like grab bars attached to near the WC, and is there adequate family support? Then the opportunity to see family members, meet them, build relationships, and see whether they are burnt out or show some compassion, and assess the compliance with your health advice and medications, and opportunistic health promotion. So you go to see the elderly woman who is diagnosed with cancer, but then you also see that there is no protection around the well. So the children in the household might be at risk of falling in there. So you advise to have some protection around the well. So that is kind of opportunistic health promotion, even hazard prevention. So you can gain more insights into the patient's family problems, interaction between family members. You can see those dynamics, who is interacting the best with the patient, and the communication between them, strengths, weaknesses within the families, who is financially more capable, who has the time to tend to the patient. You observe all these when you are there. So it is a better place for family counseling. There is better privacy, and it can enhance doctor-patient. It can enhance the doctor-patient relationship. And then there are disadvantages to the doctor. It's time-consuming. Transport, traffic, parking, and disturbances due to the weather, they all can affect. Having to examine the patient with minimal equipment, because you cannot carry your whole clinic to the patient's house, and the resources will be minimal there, and the drugs facilities will be lesser, and there might be an inadequately lit environment. The lighting might be so poor that you are unable to do a proper examination, and there might be a lower bed, so you might have to bend down and engage with the patient until you suffer a backache. And so it has better privacy for the patient, but as for the physician to carry out the consultation, it is hard with so many relatives and neighbors around. And all the anxious relatives will be around. They might be raising so many different questions. Unfamiliar environment. So, and you might feel intimidated by all these questions, interrogations. Interference with the doctor's own personal life, family life, interference with the routine clinic patients. If the patient dies, the bad news needs to be broken, and the possibility of being blamed is there. So there is much debate around why don't doctors make house calls as earlier. So there is this, reference, a book. You might want to read it. So there are advantages to the patient. So the patient and family are generally satisfied when a doctor visits them. No physical stress of being mobilized. Psychologically comfortable. They are in their own environment, less anxious, less dependent, and better able to express themselves, communicate concerns, and they will feel that a holistic care is being delivered, especially if a multidisciplinary team visits the patient. And these are some references to read again. I have told about this earlier. Where do the patients prefer to be cared for, or where do they want them to die? So they prefer to be cared for at home and they prefer to die at home as well. So which is why home visits can be more important for the patient. Disadvantages to the patient. So you need to tidy up the home, and you might feel a little bit of, you might feel embarrassed if the household is like looking shabby, and or they might not like the idea of doctor witnessing all these socio-economic problems. And they might also be concerned about the pay, having to pay the doctor more than for an office visit. So when not to do home visits, so this is some homework for you. You can decide, depending on the scenarios I give you, whether you should ideally do a home visit, or can you say no confidently. In the England and Wales, it is kind of an obligation. It is a moral obligation than a legal one, but you have to be able to justify why you are not doing a home visit. So be able to ethically and clinically justify back your decisions. So in the England and Wales, it says, outside normal hours, the doctor shall consider, in the light of the patient's medical condition, whether a consultation at home is needed, and if so, when. Scenario 1. You can pause this slide and read through this scenario and what are the implications of visiting this patient or deciding not to visit this patient. A second clinical scenario, read it and decide. Is there a difference between the two scenarios, and why do you think it is different? The factors you need to consider. So moving on to the home-based assessment, we need to assess many different aspects when you perform a home visit. So some people are good with remembering mnemonics, so which is why I have put in-home SSS here. So in addition to in-home SSS, I would also encourage you to look at the activities of daily living and instrumental activities of daily living, which you are already aware of, I guess, if not just browse what they are. They are a very simple concept. And so in-home SSS is like whether the patient is immobile, what's the nutritional status, what are the housing conditions, how about the others around the patient, the relatives, loved ones, what medications the patient is on, and is the patient compliant on these, do an examination, ensure the patient is in a safe environment, assess spiritual concerns and address them as appropriate, and see what services are available around the patient's neighborhood. So these could be the basic elements of home-based assessment. I have gotten these from the American Family Physician. And tips, the doctor's bag. So decide what you need to have in the doctor's bag. You cannot carry everything, so the essential things must be there. So there can be instruments and equipment for you to carry out examinations. Stethoscopes, BP apparatus, ophthalmoscope, oroscope, knee hammer, tongue depressor, thermometer, and peak flow meter. Then other diagnostic instruments, basic. They might be crude, but they are of good value in home-based settings. Urine dipsticks, glucometer, lancet, and strips. Then treatment or procedure materials, cotton wool, gauze swabs, surgical spirit, povidone-iodine, and other antiseptics, scissors, bandage, sticking plaster, suture material, needles, NG tubes, and Foley catheter. Then the drugs that are needed to manage emergency situations. There could be oral medications, suppositories, injections, and even other forms of fluids, IV fluids. Then you also need to have your prescription pads, letterheads to write referral letters, pens, rubber stamp of the doctor. So you have to have these there. And it is also good if you have a list of useful home telephone numbers of the hospitals, pharmacies, ambulance services. And in times of COVID, you might also need to have your the emergency contact details. So what will be the future of home visits? What will it be like? So there can be more virtual visits. Have you thought about this than physical visits? So there can be a triaging system where you decide whether the patient can be managed virtually, even dermatological conditions or anything that could be managed through an online consultation, or do you really need to do a home visit? And this has become commoner after the COVID pandemic, the form of triaging. So telemedicine, it is really something, and it is a means of achieving universal health coverage in other parts of the world. But in our setting, the patients might still not have access to all these smart mobile devices to connect with with these online platforms, and the internet coverage might also be another problem. But in due time, I think we will have more internet coverage than the healthcare coverage, where the most remote villages, the patients might be able to consult their general practitioners or specialists through mobile phones than having to visit them physically, having spent a lot of money, having wasted their time as well. And this is also a big thing. The telemedicine is also a big thing when it comes to specialist care, where the general practitioner arranges certain specialists to consult the patients in their village. So they can get the patient to visit the general practitioner, and the general practitioner arranges a virtual consultation with the specialist in the town. So that is a form of collaboration that can happen. It is also valid for palliative care as a discipline. So as we said earlier, family physicians, palliative physicians, and geriatricians are forms of specialists that are frequently involved with home visits, but any form of doctors or health professionals can perform home visits. So we have spoken a little bit about the advantages and disadvantages of virtual consultations. So the points to ponder in the end of this session would be, you should be able to justify why you are doing each of your home visits. And you need to have a strict guidance to be able to decide easily whether you need to do a home visit or not. And about the pay as well. And have a policy for that. Use your time efficiently. If you only decide to do routine home visits, allocate your time. Okay, Wednesday afternoons, I am going to do home visits for patients who are bedbound. So have your policy clearly there. So it will also be, it will also bring justice to your family, so that you have adequate time to spend with your family members. You have to strike a balance with your responsibility towards the patient while also filling the obligations towards your family. And then maintain the professional boundaries, and when you visit the patients in their households, there can be other, the patients can misinterpret, a physician visiting them. So there can be miscommunications, misinterpretations, and many other sorts of problems arising from that. So try to avoid them and be sensitive to the socio-cultural spectra of your population as well. So any questions you can post in the palliative care Google Classroom module, and you can also communicate me via the SJP or the official email ID. Thank you.